Hi, I'm Dr. Frank Speidel, and welcome to The Doctor Is In. In this program, we'd like to explore how we experience healthcare in the United States, both as individuals and as a society. I want to explore the successes and the challenges we face, and perhaps consider the barriers and opportunities that litter the healthcare of the United States. For the last 3 decades, we have seen a detonation in the United States that has claimed hundreds of thousands of lives. No, it's not a thermonuclear device. In 2017, we lost over 47,000 Americans due to opiate overdose. The trend is staggering. How do we get there? Well, relief of pain has been long-standing and noble at a primal foundation of providing care for patients. And opiates, if you pick up any journal and read, are seen as the most effective modality for treating of pain. Well, not so fast there. We ought to think that again. If I see a patient with a shoulder dislocation in the ED, I can use a lot of opiates and he's still going to have, or she's going to have a lot of pain. However, if I reduce that shoulder dislocation, remarkably, I have profoundly lessened that patient's pain. So maybe there's too much of a predisposition to solving and managing the problem of pain by using pharmaceuticals. Let's go back to the beginning. I want to talk about what happened in 1952. 3 psychiatrists, Arthur Mortimer and Raymond Sackler, buy a pharmaceutical company called Purdue Frederick. At that time, Purdue Frederick was famous for making earwax, laxatives, and a tonic that invigorated and made people feel better. The tonic had 11% alcohol. This becomes Purdue Pharma over the course of decades with a focus on pain management. And we all know managing pain is a noble cause. In 1984, Purdue Pharma came out with MS Contin, a long-acting morphine. What's remarkable about this is morphine has been around for a long time. You couldn't get a trademark, a patent on that. But MS Contin, because it was a long-acting, could be patented. And you could market it exclusively. Then in 1995, Purdue Pharma came along with OxyContin, a long-acting oxycodone. They advertised and marketed this product as having only a 1% addiction rate. Now, I find it noteworthy that when they made this statement, the 1% addiction rate, they had no real substantial scientific evidence supporting that. It was an unsupported assertion. Coincident with this, in 1995, the American Pain Society identified pain as being undertreated in the United States and a challenge, especially chronic cancer pain, non-cancer pain. They trademarked the expression, pain is the 5th vital sign, to again emphasize that physicians needed to be aware and be more aggressive in treating pain. In 1997, the American Academy of Pain Medicine issued a consensus statement, always be aware of consensus statements, that there was insufficient evidence to show that addiction occurs when opiates are appropriately, there is no addiction concerns when opiates are appropriately prescribed. The American Pain Foundation endorses this too. Now, it's noteworthy that 90% of the American Pain Foundation's funding comes from pharmaceutical concerns. In 2000, the Joint Commission issued new standards inviting a careful assessment by physicians of treatment of pain. This was based on a 1980 letter to the editor of the New England Journal that once again said there was no risk of addiction from prescribing opiates for pain. 2001, pain is the 5th vital sign, was endorsed by the Joint Commission. Now, I would venture to share some first-hand experience. In the 90s and into the 2000s, in practicing medicine, physicians were carefully educated to be able to discern the appropriate level of narcotic use for the legitimate relief of pain. Things changed. All of a sudden, there was pain scales. And we were held responsible that if we did not get the patient to having no pain at all in the emergency department, then we were failing as physicians. This was drilled into people at the bedside constantly, that we were under-treating pain. And bear in mind, most of this was based on very spurious research. The flimsiest arguments were brought forward by organizations. In 2003, the Federation of State and Medical Boards produced model guidelines for prescribing opiates for chronic pain. This was once again done without quality scientific studies. It was developed with help from a group called the Pain Policy Study Group from the University of Wisconsin. It's not disclosed in any of the publications that the Pain Policy Study Group at the University of Wisconsin received $2.6 million in funding, most of it from Purdue Pharma. Right now, Purdue suffers twice the opiate death rate of other states, such as Minnesota and Iowa. This false advertising led in 2007 to Purdue settling for $630 million, an FDA claim of false advertising. Help is on the way, though, from a most remarkable source. In 2017, the Attorney General from Mississippi, Mike Moore, sues Purdue, Endo, J&J, Teva, Allergan to recover the cost of states providing for opiate addiction. Unfortunately, by 2017, we were seeing 47,000 deaths in the United States per year due to opioids. By 2017, the Joint Commission moved away from undertreating pain to a more sophisticated, nuanced recommendation for pain treatment. As in all human interactions, from generating quarterback ratings to talking about elementary particles in physics, much mayhem results from term confusion. So let's define some terms before we go forward. Pain has been called an unpleasant sensory and emotional experience associated with actual or potential tissue damage. I find a better definition of pain being the one I learned a long time ago. Pain is a personal response to a noxious stimuli. It recognizes that there is a unique personal cognitive component, and it's subjective. The term chronic for chronic pain is beyond the normal healing time we associate. When I fracture my wrist, I think 3 months out, I expect most people will no longer have pain if there has been a fusion of the bone fragments. Another term that's confused is tolerance. Over time and repeated exposure, increasing amounts of an agent is needed to achieve the same effect, both subjective and objective. It requires more of the agent to produce the same effect. The term dependence. Dependence refers to what happens physiologically, both objectively and subjectively, when there is a precipitous withdrawal of the agent. That is sometimes confused with the term addiction. Addiction is used, for me, as the compulsive engagement in rewarding behavior despite adverse outcomes from engaging in that behavior, characterized by repetitive use of the subject to get to that level. It is a chronic relapsing disorder, compulsive in nature, in which the patient experiences a loss of control, and a loss of this ability to access the agent generates dysphoria. So much for my preface. With this, I am pleased to introduce to the real expert, my guest, Mrs. and friend, Mrs. Brenda Schivito. I know of no one more informed and understanding of addiction and opioid use disorder. Brenda is the founder and director of Angels Against Addiction, the Nicholas Schivito Foundation. Welcome to The Doctor Is In, Brenda. I'd like to start off our discussion by asking you about your educational background. You make some wonderful observations. This didn't happen by accident. Tell me about what you learned, your education.
Well, I thank you for asking me to be here this morning. I have a background in social work. I have an undergraduate degree in social work, and I have a master's in education in elementary school counseling. However, that could never have prepared our family for what happened to us January 20th of 2018. And that was the tragic loss of our son Nicholas to an accidental opioid overdose. And it didn't start there. It didn't start with opioid use for Nicholas. As a youngster, 14 years old, Nicholas was able to jump on his bicycle in our neighborhood and ride to the local convenience store, and there he was legally able to purchase a substance called Spice. This was over the counter, and it was a chemically laced marijuana, but it was legal at the time. I'm not sure of its status today, but that's where the troubles began. And unbeknownst to us at the time this was going on, it led to what we found out later to be psychotic episodes. Nicholas experienced psychosis, and he was admitted to a mental health facility here locally, and the doctors there did not know at the time what had caused this. But an addiction psychiatrist was able to identify this. She's in Baltimore, Maryland, Dr. Elizabeth Stuller. She was able to suggest to the professionals where Nicholas was being treated that this could have been the result of Spice. Okay, fast forward, we come to learn that Nicholas also suffered from bipolar disorder. And I think in many cases, that and substance abuse can be co-occurring. And as you know, as a doctor, it's extremely, extremely difficult when you're dealing with the brain and the interaction of substance use and the prescribing of different psychotropic medications to not only arrest the psychosis, but to get the brain in a stabilized state and put him in a better place and better state of mind. Well, through these experiences, Nicholas had been in different rehab facilities, in and out of rehabs, 8 times, 6 different facilities. And there's a lot of ways and a lot of ways that the professionals feel that substance abuse should be treated. A lot of different ways.
Did you ever get the feeling that some of those suggestions for treatments of substance abuse disorder were conflicting and not consistent?
Absolutely, absolutely. Clinicians, outpatient clinicians would say, oh, you need to exercise tough love. You need to throw them out of your house, because in many cases Nicholas did wreak havoc on our family. It is a family disease, and it is a disease, and it basically takes over the existence of the family in a very chaotic way. As you know, unlike other diseases, you can't take your child to get chemotherapy treatments because he has cancer, or diabetes insulin shots, to take care of the diabetes situation. So I believe, in my experience, it is like an illness unlike any others that I think we're facing in this country.
I couldn't agree with you more. Every year in medicine, there were things I felt we were going in the right direction and getting a handle on. I include heart disease. I include cancer.
Right.
One of the most frustrating things was addiction-based disorders. We certainly, my experience was we could resuscitate people from overdoses.
Right.
I could even manage the withdrawal syndrome. That can be managed.
Right.
Addiction was a challenge when I started, and it remains a challenge. And my experience is similar to yours. Some of the literature I read, even well-written material, is contradictory to what another well-written article says. I have a feeling that we are kind of stumbling around. Mm-hmm. And this is the great frontier of trying to understand addiction disorders. Understand them and you and I have talked about this. Mm-hmm. One of the things that frustrates me is when we talk about addiction disorders and the conflicts that we have, mm-hmm. trying to get a handle on them. It's for me, like when we talk about there's like one cancer that we're trying to treat,
Right.
I think that we neglect how nuanced and unique addiction in person A may not be the same as addiction in person B, may not be the same as addiction in person C. That we somehow have this view of it as this monolithic process.
Right.
Well, there may be some shared common pathways, but for me as the clinician, I don't think I was as aware as I needed to be.
Right.
I used to ask, one of the things that families I found knew a lot more about addiction treatment options than I did. And what little I did know was from who was pressing it the most, their best advertised program.
Right.
I used to, one of the things I would ask the families, and forgive me for sharing this, for a long time we neglected families in considering and involving them in the treatment. When you have a 24-year-old, they're an adult, aren't they?
Oh, absolutely. For us, we had a lot more to say about the treatment when Nicholas was unfortunately under 18 in a facility. And once he hits 18, because of our HIPAA laws, which are good in many respects and are used effectively, but if you have a little bit of an angry young man dealing with these issues and you force his hand to go into therapy or go into treatment, inpatient treatment, which 28 days surely isn't enough for this overwhelming crisis that we're facing. They would not, the doctors, psychiatrists, psychologists, whoever was dealing with him from a medical standpoint, would not include us as his parents, or perhaps the doctor that had been familiar with Nicholas for all these years would not pull them into the fold or pull us into the fold in if or what any medications that may have been suggested to help him.
Who's a better source for his past history than mom and dad and brother?
Exactly.
And unfortunately, at the magic age of 18, we have created a law that that puts the patient, who at times has got many stressing loading factors on him, as driving completely his care.
Sounds a little odd,
doesn't it? Though, you know, that loving family that have made this, have done everything to help their child, is cut out from his care. As you know, one of my great complaints is, with the best of intentions, trying to make the world a better place, we create laws, we create regulations, we create rules that work against what we're trying to do.
Absolutely.
Getting care for somebody at risk.
Absolutely. And they're not in their best state of mind to know what is best for them. Nor would I think is a doctor, psychiatrist, psychologist, who just basically met my son 10 minutes ago. It just doesn't seem right, does it? It's ludicrous in my mind. It's just ludicrous.
This is a trip down memory lane. Remember, my rule is patient A is not patient B. I can remember being on the phone trying to place a young person who's been resuscitated from an overdose with a treatment facility for the real challenge. My job was simple. The resuscitation was straightforward for the most part. The real work begins when you're trying to get the addicted person to a way they can participate going forward in their life.
Exactly.
And I can remember several times talking to that disembodied voice over the phone, who all of a sudden knew more about the patient and the family that was in front of me, that I just spent the last 50 minutes of my life with.
How does that happen?
Yeah, I don't know, but they were experts. And it's always a scary thing. The consensus of experts needs a lot of skepticism.
I agree.
Brenda, what would you share with families right now who are trying to get their loved one, dad or mom? Oh, by the way, another comment I'm going to make gratuitously. We have stereotypes about what people who are addicts are like. Any truth to that?
Absolutely not. Absolutely not. And I do need to just correct you on one number.
Please.
You had mentioned in 2017 the death rate due to substance abuse overdose was like in the
Opiates.
40 opiates. Oh, excuse me.
Opiates.
Then I'll stand corrected by your numbers then, because the substance abuse maybe
67,000.
it's over 76,000
Yeah,
from
yeah,
what I had
yeah.
data I
I
had
wouldn't be
collected.
surprised, yeah.
But nonetheless, it's way too many in our society.
And it's almost below the surface in a way. Until 2017, and people started to sue. This was passing beneath the radar screen. And if you
Absolutely.
look, there's a graph you'll see on the show. There's a graph that you just see this thing climbing
Absolutely.
from the 90s.
Absolutely.
And it was under the
Absolutely.
radar. I mean, families knew.
Right.
People in the ED knew. But
Right. But
Joint Commission was
families,
telling us we're neglecting pain.
so we should not feel any emotional or physical pain in our society, according to the medical community.
Isn't that, not according to
Crazy.
this segment of the medical community, pain
Right.
in some ways is life saying it's still going on.
Absolutely.
I want to get rid of that horrible pain. I want
Right.
to get rid of the terminal pain of cancer.
Sure.
I have
sure.
that duty.
But surface pain, wisdom teeth being extracted, I am fortunate enough to go and raise awareness in our local high schools.
Great.
And the first thing I talk to our students, they're sophomores in their health classes, and I say, you don't need an opiate, oxycodone. You don't need that for the extraction of teeth. The teeth are gone.
Thank you.
You have little incisions where those teeth were extracted. Just try a Motrin. Because
Thank
a lot
you.
of the kids said, like these dentists didn't allow them out of the office without taking this paper script of oxycodone. Now, on that note, I have to say that they've reeled it in somewhat. However, I still do not believe, and I'm not convinced, that oxycodone is necessary for a teenager's wisdom teeth, or anybody's wisdom teeth, to be extracted.
I am so agreed with you on this.
It's unbelievable. But to your point about families who have loved ones dealing with this, what an addict looks like, there is no specific character of person. It's men, it's women, it's our loved ones, it's our elderly. It's anybody who may have experienced a surgery, managing pain, and hasn't been instructed properly about those pain medications and how to wean down and, eventually wean off of them. And I think that's where the medical community may have done a disservice we've managed the pain, now how do we taper down off of this medication into something maybe a little bit safer, a tramadol or something less, not as strong as these opiates, because when you stop them, I don't need to tell you what happens.
It's a huge change for the patient. These are areas we have to grow, quite obviously. The ability of us to change our ways, to see when we've gone wrong, is a healthy sign of society. I think we're getting to a better stage, but we still have a long way to go.
Absolutely.
There is a belief, as you and I both agree, that life is supposed to be singing and dancing. The poet Lawrence Ferlin Getty said one time, the poet laureate of San Francisco said, even in heaven they don't sing and dance all the time. And, there's a time for tears and there's
Absolutely.
a time for ouches. And
Absolutely.
we accept this. This is part of being alive. And I also accept that the ability to reduce a dislocated shoulder is the biggest thing I can do to taking that patient's pain away. And the other thing is the ability, the patient, sometimes pain isn't from a physical trauma, it's sometimes from an emotional trauma.
Sure.
Those do very poorly with opiates.
You think?
Bless us and keep us. Yeah,
Right.
just to genuinely have a dialogue with your family members. And now, I know your family. You guys are the greatest family. You guys are the
Thank
most
you.
wonderful, supporting people.
Thanks, Frank.
It's ennobling to know the Schivitos. families can't do everything. It's society in general. We have to
Absolutely.
be kind to strangers. We have to gentle ourselves and take
Absolutely.
the sting out of our words.
Absolutely.
Forgive me for sermonizing, but every day in our media, every day in our environment here in the United States, abuse seems to be the coin of the realm.
It's terrible. And to add to that, being kind, being softer, being gentler, and that was my son. Nicholas
Yes.
was a very kind, giving soul who would do anything for anyone in need. And I do credit his dad to that genuine characteristic. It's such a wonderful thing for a young person or anybody to possess. And that's really what had motivated me after losing Nick, was that, unfortunately, Nicholas could not corral the chains that bound him in addiction. But through him, I was able to say, okay, this is what's happened to us. This is a tragedy that's occurred in our family. But how do you now take that tragedy and take that grief and fuel it by doing something for someone else?
Well, you're doing that right now. And I'm sure there are people who are watching this who would love to know more about your organization and a way to reach out and contact you and the organization. How can they go about doing this?
It's, the organization is angelsagainstaddiction.org. And you can reach out to me personally at angelsagainstaddiction@gmail.com. And I'm happy to help anybody who may be struggling, anybody who's unfortunately grieving the loss of a child or a loved one. I do participate in a grief support group, and it's paramount, and it's very powerful.
Brenda, I cannot thank you enough for
Thank you.
being our guest today, but for what you're doing and how you're taking one of the most tragic events and growing it to be a giving event.
Thank you.
Thank you so much,
Thank you so
Brenda.
much for having me. Appreciate it.
And thank you for watching The Doctor Is In.